All right. Well, I really appreciate the invitation and look forward to having a great discussion if we have time afterwards. So I've entitled my presentation, Prenatal Maternal Hardship and Traumatic Stress from Population Level Disasters and Effects on the Unborn Child. What happens to you may be more important than how you react to it. So I'm going to start off this talk by showing you an email that I received from a young woman in New York City in March 2020. So as you may recall, this was the very beginning of the pandemic. New York City was one of the hot spots in the world for COVID-19 deaths. So Katya wrote to me, when I was a student in university, I learned about your study of prenatal maternal stress during the ice storm in Quebec and the development of the children. Is it possible that the stress from the pandemic could influence the development of my child? So I think this is a great launching place because we're still in the throes of the pandemic. So we need to try to understand exactly what was Katya concerned about, what's the greater context of stress in pregnancy. So conventional wisdom, say from 50 or 100 years ago, was the idea that the fetus was the perfect parasite, that it was inside the womb, that it couldn't see anything, couldn't hear anything, and had no idea what was going on in the mother's world, and would take whatever it needed in terms of nutrients and everything else from the mother, even if it was at the mother's expense. Well, in the last 30, 40 years, we've been thinking more about the concept of fetal programming, the idea that the environment of the fetus can somehow alter its programming. Fetal programming very often is thinking about a very negative outcome. And that's a bit been replaced by the whole notion of DOHAD, the developmental origins of health and disease, where the outcomes could be positive, could be negative, but somehow the act of the placenta is having an effect on the development of the unborn child. So if we consider, for example, a woman who's going through the Fort McMurray, Alberta wildfires in 2016, and she's fleeing for her life and her family's life, of course, there's going to be some kind of stress. And the idea is that that stress is somehow getting through the placenta and sending a signal to the fetus to alter its development. So the placenta, in a way, acts like a perceptual organ. So in the same way that your eyes look at the environment, perceive the environment, and try to keep you out of harm's way, the placenta may also be a perceptual organ that is somehow taking in information about the mother's environment. So in this case, the mother fleeing for her life, practically through the flames of this wildfire, the signal is getting to the child. But there's a new concept, which is that of the predictive adaptive response. The idea that the message that is getting to the fetus is not simply to harm the fetus or to be a prenatal insult per se, but it might also be attempting to prepare that fetus for the outside world. So for example, this particular fetus might turn out to be highly vigilant, with the idea that the environment is highly threatening. But that vigilance, if, for example, there is no threat anymore as the child grows up, there's a mismatch between that prenatal environment and the postnatal environment. So this vigilance might actually be seen by their teachers in school as an attention deficit disorder, so as being disruptive in a way. So there's a mismatch between that prenatal environment and the postnatal environment. But when we think about this fetal programming, this developmental origins of health and disease, it's really quite complicated. So we have this stressor on this pregnant woman. And if my slides would advance, yes. And that stress can lead to some problems in the mother's well-being itself. So she can have mental health problems like anxiety and depression. This might lead to unhealthy behaviors like substance use, could lead to domestic violence in the family. And especially those unhealthy behaviors could have their own independent effect on the development of the fetus. At the same time, at the same time, the stress could have a direct effect, as we mentioned, through the placenta. It could have an indirect effect by influencing preterm birth, the risk for preterm birth. And all of these could lead to changes in the unborn child in terms of their long-term mental health, cognitive development, cardiometabolic outcomes, and so on. So it's hard to really know then also there's an effect potentially of those maternal mental health problems continuing to influence child development. So the questions I'm going to try to answer today are, first of all, what do we mean by stress? Second, what are the associations between different aspects of maternal stress and pregnancy and, for example, birth outcomes or maternal postpartum mental health, and especially child outcomes? Third, what are the kinds of things that might protect both the mother and the child? And if we have time, we can talk a bit about the pandemic. So there is a huge literature on prenatal maternal stress, but very often they mean quite different things when they talk about stress. So these pictures here indicate that there are a number of large-scale but retrospective studies of major events, population-level disasters like the war, World War II, or like natural disasters like tornadoes. Those are great, except for that when you're looking at large administrative databases, you don't have information about what actually happened to individual people. So they can establish that there is a risk factor for prenatal stress, but not very much information after that. Then there are a number of prospective studies that look at pregnant women, and they follow along the various kinds of everyday life events, if you will, that happen during the pregnancy. But these kinds of life events are really not very common, but also they're not randomly assigned. So people are not randomly assigned to get fired or to get divorced while they're pregnant. So, what does that mean, and what kinds of complications does that mean methodologically in terms of interpreting your results? And there's another huge field of research looking at prenatal maternal quote unquote stress, where they're looking at maternal anxiety, maternal depression. But there again, if a pregnant woman who is highly anxious has a child that grows up to be anxious, how can we tease apart how much of that effect is a genetic transmission of anxiety? How much of that is the prenatal maternal environment, the intrauterine environment? How much of that is also being raised by a mother who has a tendency to be anxious? So it's very hard to tease apart what exactly is the effect of stress. So what we would really like to have is animal research. Animal research is fantastic because it can randomly assign pregnant animals to stress or non-stress conditions that can control exactly the timing in gestation that the stress occurs and so on. But rats will not answer our questionnaires about how they were actually feeling or what they were thinking as they were being squeezed into a little box. So we are also a whole lot more complicated than laboratory animals. So what we really need is we need some kind of a model or a context of stress in humans. So Lazarus and Folkman have a model that they published in 1984 in which the whole stress experience starts with some kind of objective external situation or an event. And the first response of the person is cognitive appraisal. And the first phase of cognitive appraisal is to think to themselves, is there actually a threat in this objective situation or event? And if they conclude that no, there is no threat, well, then they have no stress. That's pretty clear. If they say, yeah, there is a threat here, well, then they go through a second phase of cognitive appraisal, and they try to evaluate, do I have the resources I need to actually cope with this particular threat? If they determine that, yes, I do have the resources to cope, then they might conclude that, yeah, there is a stress, but it's a positive motivating stress. If they think, no, I don't have the resources I need, then there's negative stress. That negative stress then leads to subjective distress, and then will lead to the activation of the HPA axis in the person, which will give rise to stress hormones like cortisol. In the case of a person who's pregnant, that cortisol can actually pass through the barrier enzyme in the placenta and reach the unborn child. So this gives us a context in which to really think about each one of these kinds of studies of stress. So we've got an objective hardship that happens, we've got a cognitive appraisal, the way we think about it, and then we've got our subjective distress. So in order to really gain an understanding of prenatal maternal stress, what we need is some kind of a major stressor that, first of all, happens to pregnant humans. Second of all, it has to be outside of the woman's control, and as much as possible, have that distress or have that hardship distributed randomly within the sample or within the population. It needs to be applied to large numbers of pregnant women so that we have sizable sample sizes for the kinds of statistics we need to do. It needs to affect the pregnant women to varying degrees. So we can look at kind of dose response associations between the degree of stress and the various outcomes that we're looking at. It has to affect women at various stages of pregnancy, because we believe that the timing is of importance in terms of the outcomes for both the woman and the child. And it has to be the kind of an event that will allow researchers to get in there and assess the level of exposure and the woman's reaction as soon as possible after the event. And this is where Project Ice Storm comes in. So I don't know the extent to which people in the audience are familiar with an ice storm, but an ice storm is, well, I'll describe what happened. So in January 1998, we had 5 days of freezing rain. So it was actually 3 different weather systems that moved through southern Quebec and dropped freezing rain. So freezing rain happens when the temperature is just above freezing during the day, rain falls, and whatever it falls onto is going to freeze there. And then, of course, at night, the temperatures go down. And so what happened in January was, with these 5 days of freezing rain, the weight of the ice on the electrical poles and these pylons, the weight was so great that it actually toppled the pylons, toppled electrical poles down the city streets and so on, and essentially left 3 million Quebecers without electricity, and for as long as 45 days in the coldest month of the year. So in response, there were 454 shelters that were established around the region. These housed as many as 17,000 people on a single night. The economic costs were $1.5 billion. That was the most expensive natural disaster in Canadian history. There were 27 deaths that were attributed directly or indirectly to the ice storm. These were from people lighting fires in their fireplaces, and that would go up in flames. They would touch live wires. Falling ice would hit people. People had hypothermia and carbon monoxide poisoning from bringing their barbecues and other things into the house and poisoning themselves to death. So when myself, we were without electricity for 1 week, and it occurred to me that this was an opportunity to study stress from an independent natural disaster prospectively. I figured that there were a lot of women out there that were pregnant at this time. So I created a questionnaire that we sent out to pregnant women 5 months after the storm. And from the natural disaster literature, I saw that the things that were important to look at were the degree of threat, the degree of loss, the scope of the disaster for each person, and the amount of change. So I created a number of questionnaire items that would get at each one of these aspects of exposure to the disaster. And then I attributed points in such a way that each scale would have a maximum number of points. For the ice storm, it was 8 points. For other disasters, it was a different number, but they were equally weighted to come up with a total score. I also saw, kind of retrospectively, that I had included in this questionnaire an item that I had gotten from another source, which went like this. Taking into account all of the effects of the ice storm on you and your family, what would you say have been the overall consequences of the ice storm crisis? And people could choose between very negative, negative, neutral, positive, and very positive. And I was quite surprised to see that from the ice storm, that there was many people who said that it was either neutral or positive, that said that it was a negative experience. And we looked at what they wrote in. The people who saw it as a positive experience, very often they had spent time staying at maybe their in-laws or friends. And because there was no television, there was no electricity, they were actually able to share stories. And there was a lot of support and a lot of fun in that. So in order to look at subjective distress, I saw that in the disaster literature, there's a scale called the Impact of Events Scale, revised, that looks at the severity of post-traumatic stress symptoms. And I thought that would be a good way to see how people reacted to the disaster. And so each questionnaire, this one actually was for the Iowa flood study that I'll tell you about in a minute, but asks the person about their avoidance symptoms, their intrusive thoughts and images, their levels of hyperarousal with respect to the disaster in question. So this, again, I just want to drive home the point that we're looking really at 3 different aspects of the stress experience. For Project Ice Storm, I only had these PTSD symptoms that are reported on at the time of their assessment, which is very often many months after the disaster. And in the other disasters, we included 2 scales that were peri-traumatic. That is, I know it's been 6, 7, 8 months since the disaster, but I would like you to think back and tell me how you were feeling at the time, at the height of the disaster. And so we have a scale of distress and another one of dissociation. And then another really major aspect of these studies is looking at the timing, because from the question, or from the perspective of fetal programming, it's that organ or that part of the fetus that is in a period of rapid growth that is the most likely to be affected by any kind of prenatal insult, whether it's alcohol or stress, whatever. So timing can be a very important factor here. So from Project Ice Storm, I just want to say that we identified pregnant women through the offices of obstetricians. We identified 1,140 women who were pregnant at the time of the ice storm, or who became pregnant in the 3 months following the ice storm. We sent out the questionnaires to them, 1,140, and we got 224 back. That is a response rate of 15%. So in no way can I use results from Project Ice Storm to say what actually was the situation or what was the effect on that region called the Montérégie, where we were looking at women. So on the other hand, although it's not an epidemiological catchment area type study, we can still look at the dose response between the level of stress and outcomes in the mom and the kid. So on average, the women in this study were without electricity for 15 days, and some women for as long as 45 days. They were on average 4 days without telephone. There were very few cell phones at the time, but women were without phones, some of them for as long as 34 days. Only a third of the women never left their own home. So what happened was that the power grid failed gradually day after day. More and more people lost power. And so you would move to one place, they would lose power, you'd move to the next place. So only a third of women never left their own home. Half of them moved once or twice, and 15% of the subjects moved up to 15 times. About 4% of the women met criteria for possible PTSD. This is about what you would expect from a natural disaster. But the people in this study had significantly higher socioeconomic status, education, and income than the regional averages. So again, we can't consider that this is a representative sample. 6 months after each woman's due date, we sent another questionnaire. Of those 224 women, 177 gave us permission to contact them again. So at 6 months, we got questionnaires from 176 of them. 17% met criteria for postpartum depression. That's about the norm. 8% gave birth preterm. Again, that's about what you would expect. So as I mentioned, we sent out that first questionnaire in June '98, 5 months after the beginning of the ice storm. Another one 6 months after the due date. And over the years, we have pestered these families repeatedly until most recently, when the children were young adults, now 19 years old, we were able to see them. So we saw them face to face, a subgroup of kids when they were 2 years old, 5.5, 8.5, 11.5, 6, 13, 15, 16, and 19. So I mentioned that there are other disasters. So Project Ice Storm is the longest running that went till age 19 and for which we have the most biological data. 10 years after the ice storm, we saw that there were major floods in the state of Iowa in the United States, and we collaborated with a group there. And interestingly, they had already been collecting data on pregnant women long before the flood happened. And so they had actually psychosocial data on those women before the flood. So here we have a pre-post study of prenatal stress. But what we really wanted was samples of the placentas. So in 2011, we were able to go to Australia and recruit women in the hospital. And we got samples of the placentas for those who had been exposed in their first and second trimesters. Then we really wanted to do something to help these women rather than just confirming time after time that prenatal stress has an effect. So in 2016, we had these wildfires in the town of Fort McMurray, Alberta, where a town of 80,000 people at the very end of the road, way up north, with nothing but tundra north of them. All 80,000 people had to evacuate in the span of a few hours. Luckily, nobody was actually killed by the fire, but we included an online expressive writing intervention, but our sample size was too small. So then a year later, when we saw that the city of Houston was underwater following Hurricane Harvey, this time we pulled out all the stops and we recruited over 1,000 women and tried the same expressive writing intervention. And then more recently, since 2020, I've been involved in 3 different studies of stress from COVID-19. So I'll try it over the next half an hour or so to give you an idea of our results. So the main objectives of this, what we call SPIRAL, the Stress and Pregnancy International Research Alliance. If you want to look up our papers, they're here at mcgill.ca/spiral. So the objectives of SPIRAL are, first of all, to establish what are the actual parameters of prenatal maternal stress that have effects on specific outcomes in the child, cognitive, behavioral, physical, and motor. And then what might moderate those associations? So could prenatal care make a difference, or social support, or cognitive appraisal might moderate that effect? Then we also look at, we look at mediators. So to what extent does prenatal stress influence things like birth outcomes or mental health in the mother, which might also then have an effect. And then also at child mediators. So does the stress influence brain, cortisol, epigenetics, and so on, which then might have an effect. So what I've highlighted in red here are the things that I'll be able to talk about this morning. So if we look first at birth outcomes, for example, so we did not find any main effects of either the objective hardship or the subjective distress on birth weight and gestational age at birth, but we did find a main effect for the timing, where the lowest birth weights were for pregnancies that had been exposed to the ice storm or the first or second trimester. And kind of the corollary of that is that the greatest percentage of children that were born premature were those that were exposed in the second trimester. But then we also found that there was a main effect, not only of timing, but also of the severity of the subjective stress. So remember, that's the post-traumatic stress symptoms. So here we have the birth weight, and then if they were exposed early, middle, or late pregnancy, and we have this curvilinear association, but the more severe the PTSD symptoms of the mother 5 months after the ice storm, the lower was the birth weight. So we did have an effect there. And this was something interesting I just want to throw out there. One of the results that I had that I sat on for many years because I didn't know what to do about it was that when we actually looked at the head circumference and the length at birth, we saw that the greater the mom's stress, the bigger the head, but the shorter the body. And I had no idea what to do with that. But then I was speaking with Patrick Wadois at University of California at Irvine, and he said, oh, that's head sparing or brain sparing. The idea that when the fetus, when there is a lot of environmental stress or some kind of an environmental insult, that the placenta will guide the development of the fetus in such a way that it spares the head. So you got to have a brain in order to deal with this stressful exterior environment, but you don't have to be tall. So it's not so much that the heads were big, but that the ratio was altered. And we saw that that was a function not only of the level of subjective distress of the moms, their PTSD symptoms, but that it differed for boys and girls. So sex was moderating the association between subjective stress and this ratio of head circumference to birth length, such that those boys, only in boys did the level of subjective distress have an effect on that ratio. So as I mentioned, Project Ice Storm, the study that we started with 224 women, was totally not representative of the region. So if you look at this map down here, you can see Montreal, the little black dot, and this area here is a region called the Montérégie, and that's where the disaster was the worst. And you can see that this very dark purple represents 100 millimeters of freezing rain that had fallen. And here's just 50 millimeters that has accumulated on a twig. So these were the regions that was the most badly damaged. So we started a study that we used administrative data from Quebec for the 3 years before the ice storm and the 3 years after the ice storm. So we had a temporal control, but then we also wanted a geographic control. So the Montérégie is down here in the southernmost part of Quebec, near Montreal in purple. So we gathered data not only from Montérégie, but also from here in kind of brown is the capital, Quebec City, that region, and also the lower St. Lawrence region. So together, these were somewhat comparable in terms of socioeconomic status. So we used something called the difference in difference method, where you look over time. So these are the 3 years before the ice storm. We could compare, and this is just a theoretical graph here. This is not actual data. You can see, is there a usual difference between these two regions? And is there like a trend over time? And if, let's say that this is the Montérégie with the diamonds or with the triangles, what would we expect in the year of for children born in 1998 and after? This is what we would expect if there's no effect, but then there might be a a difference. So this is what's called the difference in difference method. And we published these data on the birth outcomes recently, just a few months ago. And when we looked at birth weight, small for gestational age, large for gestational age, preterm birth, the actual gestational age in weeks, what we found was that there was no difference. We could not find that there was any kind of outcome in the Montérégie from 1998 forward that was different from what we would have expected. So we were also able to do some dose response analyses by estimating the days without power based on the postal code of these 94,000 births. And even there, we could not find that there was a significant effect of the estimated days without power. So we didn't see any kind of a major effect. So what this suggests to me is a bit like the title of my talk, is that it's not so much what happens to you as it is the subjective distress, which of course we couldn't analyze in this administrative data, but which in our Project Ice Storm we saw was associated with birth outcomes. So then let's see what, if we look forward and we look at the child outcomes. So when we look at child cognitive development, when the kids were 2 years of age, we had a small grant, $20,000, that allowed us to look at those kids whose mothers had very low objective hardship and those kids whose mothers had very high objective hardship. So more days without electricity. And we didn't have enough money to include the moderate stress kids. But when we looked, this is actually a 10-point IQ difference at the age of 2 years that is associated only with objective exposure, and subjective distress of the moms had no effect whatsoever. So 10 points in IQ, the standard deviation is 15. So that's quite a large effect. So then when we finally got our first grant when the kids were 5.5 and could look more extensively at the entire sample. And we saw that once again at ages 5 and 8, that there continued to be this significant difference between low objective hardship, high objective hardship, with no effect whatsoever of the mom's subjective distress. It changed a little bit when the kids were approaching adolescence, where there was a difference between boys and girls, where the boys continued to have an effect, this time a linear effect of objective hardship, where there was no longer an effect in girls. We also looked at the children's behavior problems, their psychological problems, using the child behavior checklist. Here I'm showing you results for internalizing problems, which is anxiety, depression, withdrawal. So here we saw effects of both objective exposure and subjective distress. And you can see the results here for ages 4, 5, 6, 8, 9, and 11 years. And with the objective exposure, we did have a significant effect of objective hardship at each age, but those effects were much more pronounced looking at subjective distress. And these are the results actually controlling for objective hardship. Now, what this means, it's hard to tease apart. So to what extent does the mom's tendency to respond to a disaster with PTSD symptoms translate to a genetic predisposition in their children to have these internalizing problems? So there it's a little harder to tease apart. Based on some of the literature, when the kids were 6.5, we decided to send out a questionnaire and ask the mothers about the children's autistic-like traits. So these kids are not autistic, but autistic-like traits can be seen as on a continuum. And here we saw that there was pretty much an equivalent effect from both objective exposure and the mother's subjective distress. So as I mentioned, we got our first grant when the kids were 5.5, so we could actually send interviewers out to the homes. And as long as they were there, we thought, well, let's take their height and weight. You know, I had no expectation of what this would do, but I thought as long as we're there, we'll take height and weight. And what we found already when the kids were at age 5.5 was that if we were to split objective exposure into high and low, that those kids whose mothers were longest without electricity, 15% of them met criteria for obesity compared to about 2% of those whose mothers had shorter or less extreme objective hardship. And that trend continued at 8.5. And by the age of 11.5, nearly 30% of high objective hardship kids met criteria for obesity compared to about 6%. And when we looked even longer, like to age 15, we saw very clearly that not only was the effect well, it was continuing on, where you might think that something that happens prenatally would wash out by the time the kids were at school age. Here we saw that the effect was continuing late into adolescence, and you can see that the size of the effect actually increased the older the kids got. So that gave us the idea that maybe we should take some blood from these kids and look at other physiological parameters, in particular insulin. So if these kids were having problems with obesity, what was this doing for their insulin resistance? So at the age of 13, we convinced some kids to come into school on Saturday mornings before their breakfast and give blood and drink the nasty glucose solution. And here again, we saw it was the objective exposure to the ice storm, so their objective hardship, that was significantly correlated with their insulin resistance from a glucose tolerance test, and not the mom's subjective distress. Another person in the lab, Franz Veru, took that blood and looked at various measures of immune function, such as cytokines, and saw that it was, again, only the objective exposure that predicted the levels of pro-inflammatory cytokines like TNF-alpha, interleukin-1 beta, and so on. So I could probably talk for 2 hours if I tried to give you all the results from Project Ice Storm. But suffice to say that we did find that there were many effects of timing in the pregnancy of the ice storm. We were very impressed that the objective hardship had the effects that it did, and that subjective distress was primarily predictive of behavioral outcomes like internalizing, externalizing problems, but also some physical outcomes. So I have a student, Sandra Lafortune, who decided to look not only at our studies, but other studies of natural disasters. And she published a meta-analysis of 37 studies this year. And for many studies, they would maybe be looking at subjective distress like anxiety or depression. Our studies and some other studies also looked at objective hardship, and our studies really looked at the cognitive appraisal. And what she found was that for all areas of child development that she looked at, there were significant effects of the severity of the objective hardship here in yellow, and also for the degree of subjective distress. But that in general, there were not that big effects if we just looked at main effects of cognitive appraisal. So then she looked within the type of disaster and saw that the effects of the ice storm were significantly greater than the effects of studies from floods, including the 2 floods that we were looking at. And our thoughts about that are that the ice storm was something that affected everybody. And so there was no getting away from it, right? Whereas floods, usually you can go a few miles and you're away from the flood and there are people there who are high and dry who can help you. But there was something about the global nature of the ice storm that had special effects. So we also wanted to look at moderators of this effect. So in particular, what kinds of things might protect the mom and the child from these disasters, from this stress. So I just wanted to show you some pictures from the Queensland floods in Australia in 2011, and just mention that actually this week there is equal or worse flooding in exactly the same region. So we want to keep these people in our thoughts. But back in 2011, I connected up with Professor Sue Kildea, who was part of a randomized control trial of 2 forms of prenatal care. Now, in Australia, all babies are born with the help of midwives. Even if they're in a hospital, the maternity ward is manned by midwives, not nurses or necessarily doctors, as in North America anyway. So what they were looking at was something called midwifery group practice to compare with standard care. So in standard care, there's no primary care. So when a pregnant woman goes to the clinic, they meet, whichever midwife happens to be on duty that day. Their prenatal care is maybe from a general practitioner or antenatal clinics or in hospital. And very often they're unfamiliar with whichever midwife shows up at the birth. So it's an unknown person. Whereas midwifery group practice, there are 3 or 4 midwives in a group. So there's a primary caseload midwife, but others in that group. So the prenatal care and postpartum care up to 6 weeks are provided, and a known midwife is there at the time of the birth. So this trial, you may be familiar with it, is called MANGO, and most of the research that they've done on just in not during the flood, but in regular time, was that this midwifery group practice is a more positive birth experience for women, and it's even less expensive than the standard care. So after these floods, we were able to piggyback onto this study and look at, for example, maternal mental health postpartum. And I don't know why my animation will never work when there are people watching. Okay, so one of the things we did was we administered the Edinburgh postpartum depression scale when the moms were 6 weeks after birth. And we saw that those mothers who were in the group midwifery practice, this line in red, irrespective of the degree of objective hardship, their depression levels were fairly low. As long as the hardship levels were low, it didn't make a difference what kind of prenatal care they were receiving. But for those women who were in the standard care, the greater the objective hardship from the floods, the higher was their postnatal depression. We also looked at the development of the kids. So this is when the kids were 6 months of age, the mothers completed something called the Ages and Stages questionnaire. And pretty much across the board, the children of mothers who had been randomized, recall, to the midwifery group practice had tended to have better outcomes, but had significantly better outcomes in fine motor and problem solving. So one of the reasons we believe that the midwifery group practice has this effect could be through social support, because those midwives and their patients really developed a rapport that was very helpful. And we had actually found, following the Iowa flood studies, you'll recall that in this study, they could control for the women's anxiety and depression before the floods and look at that trajectory over time. And they found that the greater the social support, the more the women were protected from the effects of the flood. And we have seen, social support buffering pregnant women from distress and from objective hardship in the other studies as well. So from the Fort McMurray wildfires, Barbara Verstraeten found that especially when peritraumatic distress, you remember that's the scale where we asked the women, how distressed were you at the time driving down the road with walls of fire on either side? How distressed were you? That as long as their distress was relatively low, that high social support satisfaction protected them from post-traumatic stress-like symptoms. But when the distress was extremely high, the social support was no longer effective. Barbara also looked at positive cognitive appraisal. So you'll recall that question where we asked, if you take everything about the disaster into account, would you say that the consequences on you and your family were negative, neutral, or positive? And from the Fort McMurray fire, she saw that having a positive cognitive appraisal was very protective in levels of high levels of objective hardship, where for people with a negative cognitive appraisal of the fires, the greater the objective hardship, the greater were their PTSD-like symptoms. And I put this dotted green line there to show a potential threshold for PTSD symptoms. So cognitive appraisal is one of the variables that we really kind of come to late to analyze, but it is certainly appearing to be very powerful. If you attended the talk a couple of days ago by my former postdoc, Lei Cao, she probably would have mentioned that both objective hardship and cognitive appraisal predicted the degree of DNA methylation in those kids at age 13, where subjective distress did not. So here we really woke up to the idea that cognitive appraisal was important. Another person in my lab, Vincent Paquin, looked at, again, the Queensland flood study in Australia. He looked at the mother's depression over time at 16, 30 months, 4 years, and 6 years postpartum, and saw that for those women who had a negative cognitive appraisal after the floods, that the greater their distress at the time of the flood, that peri-traumatic distress inventory, the greater was their depression over time. Whereas for women who had a more positive cognitive appraisal, the more they were protected. Okay, so what about COVID-19? So could we consider this as a natural disaster? So you'll remember that when I was talking about what is objective hardship, we have these categories of threat, loss, change, and scope. Well, the COVID-19 pandemic has all of these. You know, in terms of threat, you know, we're told every day, wear a mask, get vaccinated. We're constantly reminded with images on TV and on the internet about the level of threat. In terms of loss, there has been so much loss of jobs and income. We can consider certain loss of freedoms and change. Everything about our lives changed starting in March 2020. Working remotely, I haven't left this office in 2 years or been back to my actual office. Some people have to work with young children at home, and it changed how we did everything. I don't know how many of you were like us, you know, washing off our groceries when they came back from the store. And scope, if we think of scope in terms of the duration, well, it's never ending. And if we also think about the global impact, well, the entire globe is affected. Cognitive appraisal, it's kind of difficult to see the positive in what people are going through, although a postdoc of mine who had a baby last November was saying that it was actually kind of cool not to have to travel to all my meetings and just stay home and stay on Zoom, and also to have my spouse at home. And of course, there's lots of anxiety and depression, which would be normal responses to everything that we're going through. So I mentioned that we have a study in Australia of women. It's called Birth in the Time of COVID, or BITOC. We have about 3,000 women in that sample. And in our initial recruitment questionnaire, we included 3 very simple items. The cognitive appraisal item that you're familiar with, this time going from 1 to 7, from negative to positive. We also asked a question about resilience, When things go wrong in my life, it generally takes me a long time to get back to normal. So high scores are that they strongly disagree. So that's positive, that's good resilience. And then tolerance of uncertainty, because everything is changing all the time. So we ask this question from an existing scale. Uncertainty makes me uneasy, anxious, stressed, vulnerable, unhappy, or sad. And that was rated 0, 1, or 2. So a student in my lab, Amber Lee DiPaolo, who actually is looking for graduate school work, she analyzed from the 415 women who were pregnant at the time of recruitment and for whom we had 2-month postpartum anxiety ratings. And she found that objective hardship the greater the objective hardship, the greater their anxiety at 2 months postpartum. But for women who had positive cognitive appraisal in the blue line, there was no effect, where there was a significant effect for those who had a negative, moderately negative cognitive appraisal. Same thing for this resilience item. So women with high resilience in purple were unaffected by the objective hardship, where those who answered that it did take them a long time to bounce back. So women with low resilience, they were significantly affected by the objective hardship. And the same with tolerance of uncertainty. So women who indicated that they were not upset by uncertainty, they were unaffected. First of all, we had a main effect, no matter the severity of the objective hardship. But those who were very intolerant of uncertainty had the worst effects. Okay, so what I said I would be talking about is the idea that what happens to you may be more important than how you react to it. So we saw a little bit of a mixed response to that. But yes, we do see that the degree of objective hardship, so just answering objective questions, how many days without power, how much did you lose in income, and so on, that this predicts a lot of outcomes in child development, but especially when assessed at the individual level. So when we looked at the population of Quebec and compared those two regions, we really were not able to see very much. And even in the PITOC study of the COVID pandemic, when we look at the number of deaths in the region that has no discernible predictive power, unless we're looking at the individual level, like how much did you lose? Do you have children at home, and so on. So objective hardship predicts many outcomes, but especially the cognitive and the physical development in the children. However, we did see that subjective distress, so the way the women were reacting to the disasters, did play a role in some things, such as birth outcomes. And that might be why when we looked at the administrative data that we didn't see any effects. And we do see that there is some effect of subjective distress on mental health of the children, but there may be a genetic explanation for that. We also see that maternal personality factors can be predictive, like their tendency to think positively, their self-perceived level of resilience and tolerance of uncertainty, and that there are other things in the social environment that can be protective, like the quality of prenatal care and social support. So this woman who wrote to me from New York City in March 2020, in my explanation back to her, in my response, I mentioned that I think of a child as a bit like a beef stew, where the most important big chunks are really the genetics, that those genetics are going to establish kind of the high and low levels, so the range within which the child will develop. But then other things can kind of push that child up and down that genetic range. Like the potatoes are pretty big, so that could be maybe the diet or vitamins. You've also got the carrots. That might be, did the mom drink alcohol or take drugs? And the peas might represent stress from COVID. So yes, we are seeing effects of prenatal stress, but those effects are relatively minor and probably less important than some of these other things. So I left her with this thought that your baby has way more advantages being desired by loving parents who are intelligent and articulate than disadvantages. So Alessia, this woman in New York City, did send me some pictures. Everything turned out all right. And Alessia is growing well. So that's all I'll mention today with the time that I have. And so many different people helped out on these studies. And I just want to mention that if you are interested in prenatal stress and child development, this book just came out a few months ago, edited by these people with a dozen chapters. I have a chapter in there that summarizes all of our results from the various studies. So I want to thank you very much for your attention. I'm just going to leave you. I'll leave this slide up here. This is all the stuff I didn't have time to tell you that you might be interested in, but I'm happy to take questions if the organizers think there's time.
Thanks, Suzanne. My mind is blown. Thank you. I always have lots of questions, so I probably won't start with my own. So I'm going to go around the floor. So Antje from Switzerland has a question for you, Suzanne.
Thank you very, very much for a very interesting and inspiring talk. I just wondered, when you talk about hardship, what is
I'll ask somebody to repeat the question because I didn't hear it. Repeat the question in the microphone.
Can you hear me now, Suzanne?
Oh, yes, of course.
Yes. I was saying thank you very much for a really inspiring talk and congratulations on your wonderful body of work. I was just wondering, when you talk about hardship, to what extent does the duration of the stress play a role? So I was wondering, when you talk about hardship, you obviously focused on, for example, the 7 days that the ice storm lasted. But what happened afterwards? So presumably then for some people, life, houses were rebuilt and electricity was gained again and people sort of restarted their lives. Whereas I guess for some people that wasn't the case. So for me, the question was hardship, where does it end? And to what extent were you able maybe to account, I guess, for these differential effects, if that makes any sense?
Yeah, so in each one of the studies, our objective hardship questionnaire asked a lot of questions, had a lot of items, fairly factual items, on what date did you lose electricity and what date did it come back? When did you leave your home? When did you come back to your home? Which was really hard for the Fort McMurray wildfires, for example, because so many people lost their homes and they never went back. So we've had to figure out how to code these items. But so the duration is part of the scale that we call scope, both the duration and the intensity. So like the density of the neighborhood that was affected and so on. So this all goes into a larger equation. I would say that for Project Ice Storm, because we only had 2 items for scope, one was the number of days without electricity, the other was days without telephone. The duration was very important. But what also comes up sort of behind your question is the difference between an acute stressor and a chronic stressor. And I feel very strongly, not only based on my own work, but on based on a lot of other studies, that there's something that happens when all of a sudden the world changes for a person. And so we have always used the timing as the date of the onset of the big change, or the date of the onset of the disaster. So, we've seen over and over again that timing, where it happened in the pregnancy, really is what determines which system in the child is going to be affected. for the pandemic, we're all still scratching our heads. So with this study in Australia, we had a recruitment questionnaire, but then the pandemic keeps going. So we'll say, okay, so now at 2 months, we're going to ask them, okay, 2 months postpartum, we're going to ask them what's happened throughout the entire pregnancy. And then, my gosh, it's still going on. So we have another questionnaire at 6 months where we ask what's happened since the birth in terms of the pandemic. And now we're at 12 months and we're just putting together the 24-month postpartum questionnaire. And so the pandemic especially is a fantastic opportunity to see what happens over time with these really, really long disasters, population level disasters. So I don't have a really good answer for you at this point, except to say that we're very much taking into account in every one of the disasters, how long it lasts. But I think the pandemic results are going to really tell us a lot about the difference between the acute onset, because I don't know about you, but I thought March and April 2020 were the most stressful parts of probably of my life, except the ice storm. So we'll be able to say eventually the difference between the acute.
Thank you very much for that response. I suppose what I was wondering, just a small follow-up question, did you ever ask people at when did they start feeling safe again? So from their subjective perception, when did the exposure stop? Or was it always that you defined the length from an objective point of view, if you want to see what I
so what we did, especially with the pandemic, because the PTSD questionnaire didn't make any sense, the peritraumatic distress, those questionnaires didn't make any sense at all for the pandemic. And so we created our own scale of the subjective distress. And so at each one of these time points I mentioned, recruitment, 2 months, 6 months, 12 months, now 24 months, we always ask just their level of distress. So it doesn't answer specifically. I really like your question about when did you feel safe again? We've never asked that to anybody. But we should be seeing that in these questions about how distressed are you about this or that aspect of the pandemic, and when does that go very low? But that's a great idea. When did you feel safe again?
Suzanne, that's amazing, and I'm looking forward to seeing the data published around the women who had their second birth during the pandemic and how it varied. You were talking about acute versus chronic, like at what point does it become chronic, especially with the introduction of vaccination and things. So we're very interested to see the fact that the pandemic itself changed and our management changed. So fascinating to hear more from you in the future. So for now, Suzanne, we say thank you so much. It's been, as I said, the silver lining in the pandemic is we've been able to have you virtually with us. We mightn't have been able to do something like that before. So we're so very grateful for your time and for sharing with us today. And we just want to say thank you so much. And please do keep in touch. Thank you. Thanks,
Thank
Suzanne.
you very much. And I hope to visit the wonderful country. I've heard it's beautiful.
Thanks, Suzanne.